This meeting is now being recorded.
Okay, so a reminder again to star six your phone to mute yourself. That just keeps any background noise from interfering. And star 6 to unmute yourself if you have questions or comments. So, today we're going to talk about care coordination, and specifically the care coordination projects that WWC is working on, worked on in the past, and will be working on in the future. So, last year, WWC, did a pilot project, and what we called the Care Coordination Pilot Project. And the purpose of that project was to help women who are otherwise eligible for WWC either get enrolled in health insurance if they're not already enrolled, and then help them navigate them to complete their screenings and diagnostics if they had abnormal screenings. So we had 2 participants actually volunteered last year to do this project, Boulder Valley and Peak Vista. We did a pilot project so we could learn a little bit about what it's like to implement the project at the agencies. We had some thoughts about, this should be pretty easy. You just offer the same services to new women or to these women, even if they have insurance, and piece of cake. And we learned that that's not necessarily true. But through this project ran from March through the end of the fiscal year in June, and 131 women were served. It was a short time. We used the same type of funding structure, the bundled payment system with the levels and that kind of thing. So, for example, the B7 and the C7 agencies were reimbursed for navigation to navigate a client to completion of either a mammogram or a pap test with or without the HPV, just like levels B2 and C2. Levels B8 and C8 were agencies who were reimbursed for completion of breast and cervical diagnostic tests. So that abnormal and up to the point of treatment. Agencies were, one of the things we did during this project was to have monthly conference calls. And it was really for us to learn about what was going on and to help agencies figure out how to get over some of those hurdles. But really, those 2 agencies taught us what to do. So some of the things that we learned that, and actually we just had a conference call with the current grantees talking about this very same thing, is it's a little difficult explaining this program to clients. It's like, I'm coming in for a mammogram. I'm already here for a pap test. Why do I need this? Why do I need to sign another form? What are you doing? So we've learned a few things about that. We also learned that agencies are spending a lot of time navigating clients who don't need screenings. And in the pilot project, we weren't providing reimbursement for some of that. We also learned that about 1/3 to 1/2 of the clients that did the agencies were screening or seeing for the care coordination were former WWC clients. So WWC clients who now have insurance, and they're still coming to your agencies, and now they're continuing their care there, and now the agencies are being reimbursed for that case management, that care coordination piece, that patient navigation, and because they're still doing that work. And we also learned that there's a big difference in how different agencies manage care coordination, implement it, and that we needed to ensure, build in some flexibility as we moved forward to develop this, what we're now calling the Care Coordination Grant Program. So, in the end, we asked agencies to really give us, so if you could change 2 things about this program, would you, what would they be? And the biggest problem we had was the consent form. So the consent form is required for the program, but our original attempt was way too wordy. We tried to explain way too much, and it was just too much. So we listened to that and actually created a combined care coordination clinical services form. So the agencies who are now doing the program, the current grant program, are using what we're calling the combined form. I can't remember what we're calling it.
We call it a dual consent.
A dual consent. So there are really 2 columns. And they don't have to worry about this form is for WWC Clinical Services and this form is for WWC Care Coordination. Just one form. And so we actually we listened, and that was a big improvement for the upcoming program. And also this piece of where not paying for clients who are not receiving their mammogram or their pap test, not reimbursing for that. And we heard that, and we're, what I want to tell you is we're still working on our payment structure in that area, but there have been a few improvements in the new program. So, in last October 2014, WWC released what was called an RFA, a request for applications, and we had a really fast turnaround time to submit. I don't even remember. It was less than a month, absolutely less than a month. So, and we've talked to a lot of you to find out, well, why didn't you apply? And we found out that was really a big factor. So, I'm just going to talk a little bit about that, about what the Care Coordination Program is and does, and some of our numbers and that kind of thing. So, the purpose of this program is pretty much the same as the pilot project, but basically we are reimbursing agencies to provide those that patient navigation and case management services to insured clients. And really the overarching goal of this program is to increase the number of women screened for breast and cervical cancer. It's a separate contract from clinical services, so agencies are in eCaST entering, or they'll have like 2 different grant activity statements and that kind of thing. This program, the current grantee started about February 1st, and it will go through June 29th, 2017. And I wanted to highlight that we do have some information on our website. There's a section in the toolkit that is about this program, and there are some other pieces on our website, some forms. You can take a look at the forms and that kind of thing if you're interested. So, we have 14 agencies that we contract with to provide that care coordination for eligible insured clients. Here's the first half. Here's the second half. And you will notice that, I don't know if it's connecting for you, but they're all currently also providing clinical services. So the RFA was opened up to any agencies that provide clinical services, but it just happened to be that those that applied were current contractors. Let me tell you a little bit more about the program. So agencies, so a woman comes in, and if you look at the first 1, 2, 3, 4 lines are pretty much, that's WWC eligibility. So agencies are required to determine if a client is eligible for WWC clinical services or care coordination. And so all the eligibility guidelines are still applicable except for that insurance piece. So the agency would ask, find out the insurance status. If she's insured, she's part of care coordination. If she's uninsured or underinsured, she's part of the clinical services program. So, and agencies are really encouraged or required actually to enroll women in Medicaid if she's not already insured and she's eligible. So agencies are required to provide these patient navigation services to assist clients to the screenings, and then case management for if there are abnormal screenings. It's very much like the requirements for WWC for clinical services. Agencies are also required to collect data and complete data entry for all screening and diagnostic procedures that are completed and entered into eCaST. Clinical services requirements are a little bit different because insurance pays for the clinical services. So they're not, we don't reimburse for that piece. Agencies must be contracted as a Medicaid provider and or be successfully billed a private insurances or any for breast and cervical screenings. Because of that, pre-approval for procedures is not required, subcontracting is not a required piece, but agencies do need to be able to refer clients out for services that are necessary. Agencies also required to comply with the tobacco use assessment policy and the quitline process pieces. The other thing I want to call out is that CCGP, Care Coordination Grant Program clients, they're not enrolled in BCCP. And it's because they have insurance and they're ineligible for BCCP Medicaid, but because that insurance covers the treatment. So agencies in this program are required to establish those relationships, not only for diagnostic referrals, but for treatment referrals. We have quality indicators for this program as well. Big difference is the CDC doesn't require specific clinical measures for us for this program, but we received funding for care coordination by indicating that the clinical core indicators would be gathered and reported in aggregate to the CDC. So because agencies are entering data into eCaST, we can review and report performance to the agencies, and we will be working on a progress report for our care coordination agencies and that kind of thing. So you'll notice that the 90% of clients with abnormal screenings have complete follow-up, yeah. That's just the exact same indicator as with clinical services, and 75% or more complete within 60 days or less, exactly the same. The third one, 35% of these clients 50 and older receive cervical services, must also receive a mammogram. So we added that in as a special program requirement. And just as an FYI, in the pilot project, the agencies met this indicator easily. They had 59%. So that 35, we may have to rethink because it seems like it's a fairly easy indicator to me. And we also have the data entry timeliness requirement for this program. So let me show you a little bit in more detail about the reimbursement. So we use the bundled payment system, as I talked about before, just like with clinical services. What we've done is included the patient navigation and then the case management reimbursement fee at the same level as we do for clinical services. So, for example, a B7, a patient is navigated to complete screening mammogram, is really the equivalent of a B2 in clinical services. A B8 is the equivalent of a B3 and B4. So in clinical services, that $60 case management fee is added at the B3 level and included in every B3 or 4 that you're paid for. So you'll notice that there are no mammogram fees, no office visit, nothing. That's because this program only pays for that navigation and case management. The cervical level is just like the clinical services. In clinical services, the navigation fee or reimbursement is included in the C1 level, and in the case management, sorry, got distracted. The case management is added at the C4 level for clinical services. So that's our logic this year. How we do our bundled payment system chart, and I think the thing to remember is we're always looking at this and trying to figure it out. I have one more section, so do you want to do that after? Oh, this one? Oh, what?
No, I know you were going to see if any of the current.
Oh, yeah, I'm sorry.
If you want, I just wondered if you want to do that before or after.
You can do it after.
One page?
Yeah.
Here. All right. So, this is Emily. Hi, everybody.
Hi.
We've had questions, well, not questions, but I know that some agencies would have liked to have applied for the RFA but didn't have the time or didn't know about it or didn't realize what it was, or, there's a variety of things, which is why we are having this call today to tell you all about it. So we are working on a request for proposals. So in the past, we did a request for applications, but this time it'll be a request for proposals, and that is due to some complicated stuff, mostly being that you're classified per federal regulations. Care coordination and clinical services are classified as a vendor-contractor relationship versus subrecipient. Don't ask me So if you're doing vendors, you're requesting proposals, not applications. So we are doing the care coordination RFP. We're working on it now. It will be, our plan is to release that first because we want to do that first. But just FYI, we also are working on an RFP to get additional clinical service providers. That probably doesn't matter to any of you because you all are already current, already contracted, but this is just, you know, our sort of now annual thing of, is there anybody else out there that wants to join our WWC family? So care coordination will be open to clinical service providers who are funded by WWC, but also ones that aren't funded by WWC. As Chris said, we didn't happen to have anyone from a non-WWC agency apply in the last round, but maybe in the future. So because it's an RFP, the requirement is that it will be announced and you must apply through the Colorado VSS, which I'm forgetting what that stands for right now. I probably have it somewhere. Vendor SS. So what you all, if you are interested in applying for this or will eventually be interested in applying it, is to go to the website, and I think you could just Google Colorado VSS and just make sure that your agency is listed. I'm told that if you already contract with the state that you are, but you know, good idea to just double check that because this is an area I've never dealt with. So if your agency does have an account, my fiscal people want me to emphasize that you should not re-register or change anything or it'll screw stuff up. But just see, and if you see your name, say, good, thumbs up, go me. And if you do need to register, there's a vendor registration quick start guide, and it's on the website. So also word on the street is that's not that hard. So I just want to make sure that's different than how we've done things in the past.
Vendor self-service.
Vendor self-service is what that SS. Hey, it's like our employee self-service. We have ESS. Okay. So we do not have the specific timeline. We have to go through a different process with our procurement people. So we're in the queue, not queue, but in the queue, different queue. And so we can't guarantee a start date. We're hoping for this fall that it would be announced like this summer and we could start contracts this fall, but that will all depend on when we come up in the queue. And then it will go through, it'll be where you get your funding annually, but it'll go through June 2017, just like all the other care coordination contracts we currently have and your clinical services. So that's not a lot of information, but that's what we have for now. It's not, well, I don't know what it'll be like this time. It was not a hard application last time. It was just a couple questions, so it will probably be similar because especially if you're already funded, how we did it last time, if you're already funded through WWC, we already knew some information about you, like that you know how to do breast and cervical cancer screenings and have providers and know how to enter data in eCaST. So we just had to ask a couple additional questions. So hopefully it'll be similar this time around. Of course, all subject to the procurement people telling us what's allowed. Yes. So it was just, I know you're used to RFAs. Maybe you've done some RFPs. There is some differences in in an RFA, you're an awardee, but in an RFP, you will be an offerer. It's,
that's going to be hard for us to remember.
Yeah, it'll mostly be us having a problem. And how we evaluate it and stuff is different. But we'll let you know as we know more about that.
Yes. Stay tuned. So, are there any questions about any of this? Remember to star 6 your phone to unmute yourself.
Chris, this is Nora. I just want to confirm. So the only care coordination services that are expected is what you've outlined in this PowerPoint?
For the separate care coordination, yeah. You might take a look at the toolkit, look at the website, and look at that section. You know, I did kind of summarize, and so, you know, but pretty much, yeah, I think so.
The vision behind it, I'm going to do my little vision statement now.
Yay.
Is, well, one thing we're trying to work towards is that these people walk through your door, these women, 40 to 64, below 250, lawfully present. That's a subgroup of the women. And that all of those women get this care coordination. I mean, you're already doing it for your WWC clinical services. And then eventually can we get to a place where they all get the same patient navigation and case management, but if they don't have a payment source, we pay for it. Like in the future, if we can combine this all into one contract, it would be awesome. They won't let us do that right now. I've tried. So the idea is you're already doing this patient navigation. It's the same patient navigation and case management you're doing for your clinical service clients. We're just kind of breaking that off and pulling out the part where we pay for the mammograms and the PAPs and things, because these people with Medicaid and insurance don't necessarily need it.
Right.
So that's really where the vision is. It's not that it's wildly different. It's really do what you've been doing for your WWC clients, your clinical service clients, but now, you know, maybe it's even the same client now has Medicaid, but you're just giving her the same kinds of services. And obviously that patient navigation and case management looks different. We're hearing, you know, it's a little bit harder maybe, or easier, or because who takes Medicaid? That's different than who do I have a subcontract with, you know. How do I get them in there? How do I get them there? So there are differences, but it's the same idea.
I guess what I was thinking about were two things. One was when you had that targeted case management piece for like education, it had to involve a provider. This doesn't have to involve anybody but the navigators. That's my first question.
Are you talking about the targeted screening mammograms for 40 to 49-year-olds? Yeah,
right.
So the provider has to
have a comment. So this doesn't require something of that nature?
Well, I mean, they would have to get their...
So it's going to look very different, right? Because their insurance is going to dictate whether or not a 40 to 49-year-old qualifies, not WWC. So it's figuring out if they have insurance, which is the preventative screening, so it should cover that.
Yeah, but I guess my concern was there doesn't have to be a documented
conversation,
with the provider, and because that was one of your requirements of that targeted piece, was that there had to be in the chart a documented conversation between the provider and the patient, and I'm just trying to see if this has the same type of requirement.
No, it does not have the same type of requirement.
Okay.
You would have to document that she got her mammogram.
Yeah.
Right. No, and I understand that. I'm just talking about the documented educational piece by the provider.
Yeah, and it's kind of interesting how we've shaped this. We did really try to shape it using what we were doing for WWC clinical services as, like, do as much the same as we can for WWC clinical services, just extend that to care coordination versus reinventing it. So I think, like, we could have gone to a place, you know, it's interesting and maybe a little bit different in that we pay based on did she get the mammogram, did she get the biopsy, did she get her diagnosis, where we could have created a whole different system that says we'll pay if you document that you called her 4 times and that you did this and that you did her, you know, that is sort of the flip side. We could have paid based on what you actually did, but we're basically saying if she gets that, that's the evidence that you did the patient navigation and the case management.
Okay, thank you.
But yeah, I mean, I could see where you would. Yeah. And that was to align with how we do it for WWC, clinical services.
So what you're asking reminds me about something I really didn't talk about. Payment is still based on eCaST and case closure and that kind of thing. So if a client needs a biopsy, then the agency isn't paid until that biopsy is completed, entered in eCaST correctly, and all that kind of stuff. And then the loss to follow-up policy is still in place. The frequency of PAPs is still in place. Just all those kinds of things, the guidelines for screenings and the algorithms for abnormal screening or abnormal follow-up is still the same. Any other questions? I want to ask if there are any agencies that are current care coordination grant program participants would like to help anyone else understand the program, or if you have any advice, or if you have any comments. Do you like the program?
This is Sarah from Uncapadre, and we are currently involved in the Care Coordination Grant Program. And I think it's really crucial to have it to help women get screened for breast and cervical cancer screening and have someone help them walk through all of that. I think it's important that now you've done that for, insured people as well, because I think sometimes even with having, insurance, they feel a little lost.
Mm-hmm. Thank you, Sarah.
And I think Sarah speaks to kind of our thinking behind it, which was, okay, all these women now have Medicaid and insurance. That doesn't necessarily mean they are going to get screened automatically or know what to do with it or know how to navigate, which is what is probably an even more complicated system.
Yeah. I just wanted to make a comment. This is Q, everyone, that I would, as this RFP comes out, I really would encourage those agencies that haven't participated to participate, mainly because of what Sarah just said. I know that when we put out the RFA before, it was a short turnaround, it was something new, it was another thing to do. But, I think it is key in terms of getting more women screened because of the changing environment in insurance and the ACA and everything. Yes, the women themselves are having more and more to think about, and if we can help them through this and guide them to get these screenings, more women will get screened. So I would really, really encourage those who aren't participating yet to really put in an RFP when it comes out, because I think, even with the agencies that are participating, there was a lot of hesitancy at first. And the first couple months, I would say, even the first month was really slow, but, now we're 3 months in and we're getting reimbursed for these services, case management and or patient navigation and case management, and that will increase the overall number of women getting screened. So please, please, please keep that in mind. And thank you for your continued work in this.
Yeah. I
should have filmed that.
we very inspiring. Thank you. Very good. Well, and one reason we we did the HIT call and all this, is as soon as that RFP is posted or whatever it's called, we can't talk about it anymore. We can't answer questions. We can't do, I mean, there will be like a formal question and answer period, but that's about it. So I just wanted to let you know, look at the website, look at the toolkit, ask your questions now. And of course, you know, when it's released or posted, you will be notified, don't worry.
Hey, Chris, it's Heather at Tri-County. I have a question.
Hi.
So I'm sorry I joined late, so I hope that this wasn't already covered, but so is there any, especially since it's on its way of coming out for the RFP, was there any discussion about the services being at a provider that isn't a WWC provider? So like, since we don't see patients who have insurance, it's really not an option for us, but we might have something coming down the pike that could allow us to care coordinate patients from another provider. Is that anything that could be potentially discussed as a possibility?
We're writing it down. It's not exactly in the scope of what of our current plan, but we are always trying to figure things out.
We are kind of going to be doing some other care coordination for other providers since we are not a primary care provider. And so it would actually be a really nice fit, potentially. I can't say that that's even something we certainly would want to pursue, but it might just be something to think about.
Yeah. Let us think about that.
Yeah.
Okay. Absolutely.
We can definitely ponder that a little bit. Our original thinking was, you know, these clients are coming in your door with Medicaid, and that it's a lot easier to navigate them if you are able to serve them yourself, you know, down the hall or whatever. Right. You know what really the biggest issue, now I'm remembering it. It actually came up, I think, in Connect to Care. It's that access to their health information. If they're not your client. Right. And so it would just be, that would be sort of part of our project. So we would have that. But we could talk offline about it.
Yeah, thanks.
A good thought. I was trying to remember. I knew there was one main kind of thing that made it tricky, and that was it. It was if they're not, how do you access their PAB information there, you know?
Right.
It would just be a really interesting thing to consider. I wouldn't think just for us either, if there's anybody else out in the community that could provide care coordination services for someone who may not really be a WWC provider already.
Okay.
Yeah, no, that's a good thing, and it's a good time to bring it up now, because again, once it's done, it's done, and we're still writing it right now. Yeah. Okay, thanks.
Any other questions?
This is Darlene at Teller. On that note, just kind of, I didn't bring this up earlier. I know we already have the coordination expansion here, but because we are not a primary care provider at Teller County either, we did run into some snafus with the PCPs when we're dealing with abnormals, because they get the results too, and there has been additional care coordination to make sure that we're both following up and not giving mixed messages to the clients and stuff. So what Heather is saying is important, you know. Because we're seeing it, not a lot of WWC contracted people are already primary care providers, so then there's not that problem. But us public health agencies that aren't doing that, it can become an issue, and it is needed out there. So.
Oh, thanks, John.
Thanks.
Anyone else? Well, Thank you, everyone. If there's nothing else, anyone in the room?
Thank you.
I'm going to stop recording. If you're not sure you were on roll call, wait.
Thanks, Chris.